Welcome to this series of lectures in oral medicine, this one entitled Potentially Malignant Disorders. The concept of precancer arises from the fact that in longitudinal studies, it has been shown that certain lesions initially thought to be pre-malignant go on to malignant change. Some of these alterations, seen in red and white lesions, also occur on the margins of oral mucosal squamous cell carcinoma. Some of these lesions share morphological and cytological changes, also seen in malignancies, but they don't often go on to invade, invasion is a hallmark of malignancies. Some of the chromosomal or genomic and molecular changes seen in OMSCC are detected also in pre-malignant lesions. So this is the evidence given for precancer. But we do know that cancer is not, or the development of cancer is not a linear process where it goes from normal to dysplastic to carcinoma. Normal can go to carcinoma, mild dysplastic can go backwards to normal. So potentially malignant disorders, the term implies that not all lesions and conditions described under this term may transform to cancer, but there is a family of morphological alterations, some of which tend to have a higher risk of malignant transformation. So from a historical point of view, the term leukoplakia is a clinical term used to recognize white plaques of questionable risk where you've eliminated any other possible underlying causes. Previously, it was classified under homogeneous and non-homogeneous, but more recently, potential malignant disorders are classified as leukoplakia, which includes mixed red and white lesions, or erythroplakia, which includes mixed red and white lesions, and PVL, or proliferative verrucous leukoplakia. And the definitions over a 10-year span have undergone many changes, and this is shown in this diagram or table. And with regard to a term or a definition, a term or a definition that actually helps the clinician better classify and therefore give better direction to management is a better term to have. And I suppose with the complex nature of leukoplakia and or precancer, it has been very difficult to try and get one term that describes all of that. So a provisional diagnosis of leukoplakia is made when a predominantly white lesion at clinical examination cannot be clearly put into any other disease or disorder. So for example, a white lesion that doesn't look like an infection or lichen planus, no other underlying cause, then you carry out a biopsy and a definitive diagnosis is made, and usually that may come back with hyperkeratosis with or without dysplasia or OMSCC. And some of the disorders that we need to exclude for the diagnosis of leukoplakia, as suggested by Wanaklusuri et al., are included in this table. And as you can see, that there are some of the common things that we see, lichen planus, lichenoid reaction, are indicated in that, as well as infections such as candidosis. Differential diagnosis of erythroplakia, which is a predominantly red lesion, which cannot be classified into any other underlying cause, include inflammatory immune disorders, such as desquamative gingivitis and some of the lichenoid and pemphigoid lesions and pemphigus, infections such as candidosis and haematomas or benign neoplasms and malignant neoplasms such as hemangioma, which is a benign haematoma, and Kaposi sarcoma, which is a malignant neoplasm of vascular origin. If we look at diagnosis of leukoplakia in 2007, this diagram was suggested, where if you've got a white patch, you exclude any other conditions or disorders to arrive at a provisional diagnosis of leukoplakia. Then once you carry out a biopsy, it might indicate a known disorder, in which case leukoplakia, or basically if the disorder is known, then you revise your diagnosis according to that name and manage accordingly. Whereas if the biopsy doesn't hand out a diagnosis of a disorder that is known, then we term it leukoplakia. And if it's got dysplasia, then it's leukoplakia with dysplasia. If it hasn't got dysplastic features, then it's leukoplakia without dysplasia. So let's just recap on some of the work that we discussed in previous modules. And we're basically talking about the epithelial layer. So this is the squamous epithelium, which is a surface layer beneath which is the connective tissue component. So we're only really worried about the pathology that's occurring in that small section of the mucosa. And in that you can have benign lesions such as papilloma or squamous cell papilloma, verruca vulgaris if there's a virus infection involved, focal epithelial hyperplasia or HEX disease, which involves HPV infection 13 and 32, granule cell tumor, and keratoacanthoma, which may appear like a carcinoma on the lip. Then you've got the malignant epithelial tumors, such as oral mucosal squamous cell carcinoma and squamous cell carcinoma arising from non-oral mucosal epithelium. So if we cover benign papillomas, which is a hyperplastic wart-like localized proliferation, it's an exophytic lesion. There may or may not be HPV present within the lesion. And the papillomas are subclassified under with the squamous cell papilloma, condyloma cregnatum, and HEX disease, focal epithelial hyperplasia. The etiology is that it's a benign tumor of surface epithelium. Usually an exophytic lesion may have a pedunculated sessile nature. Usually it's painless and excision is normally curative. So these are some examples of squamous papilloma with this wart-like appearance in some of them. Keratoacanthoma is a benign tumor that is believed to arise from epithelium of hair follicles, which occur on the lip, and a lesion which clinically and histologically may represent squamous cell carcinoma, but which usually regresses, and the male to female ratio is greater for males, and usually in a later stage. So a lot of common things with the OMSCC. And the cause of the keratoacanthoma is not known, but it's considered that there's proliferation of epithelium from the hair follicle. So they appear to be elevated lesions with a central depressed core, like a crater, and they occur on the sun-exposed hairy skin. This may be painful, but usually begins as a small nodule that develops to a full size over 1 to 2 months. And it might stay like that for a couple of months and spontaneously regress. Diagnosis is usually established with an excisional biopsy, but otherwise no active treatment is necessary. So you can see that this can give the appearance of a squamous cell carcinoma, but it's a benign lesion. And here's one on the face. So under histopathology, we look at the papilloma. You can see fronds of epithelial growth like a cauliflower with a core of connective tissue in the middle, which is quite vascular. But if you look at high power, these cells are normally uniform. There's no features of dysplasia. And the same goes with the keratoacanthoma, no obvious epithelial dysplasia, but you've got this keratin plug in the middle of the lesion. We now turn to malignant epithelial tumors of oral region. WHO classification of malignant tumors in 2005 classified many sub-headings under squamous cell carcinoma, and these are mainly based on the histological variation seen in these lesions, but they're all carcinomas, and they do need to be managed aggressively. And then you've got a lymphoepithelial carcinoma, which has a component of lymphoid and epithelial tissue within it. So squamous cell carcinoma is an invasive epithelial neoplasm of varying degrees of squamous differentiation. So where the architecture is quite recognizable, right, compared to the normal, or towards the normal, then that's called well-differentiated squamous cell carcinoma. Where it is poorly recognizable, then that is poorly differentiated squamous cell carcinoma, and the poorly differentiated ones tend to be a little bit more aggressive. And it's by far the most common malignant tumor of the oral cavity, accounting for about 95% of all oral malignancies. And in Australia and New Zealand, they form less than 3% of all malignancies. But in some other countries, they may be as high as 40% because of oral habits. So morbidity basically expresses the occurrence of the disease in the live population, and it can be considered in two ways: either as an incidence rate, the number of new cases of a disease in a defined population. So, for example, in 100,000 people in any given period of time, 1 year. Prevalence is the number of cases of the disease in a defined population at a specific time. The site of oral cancer varies greatly depending on the geographical location, ethnic group, and the habits of the particular population studied, but is good enough to say that lower lip oral cancers form 25 to 30%, which is more than in the tongue, which is 20 to 25%, which is more than in the floor of the mouth. But high risk sites are lateral margins of the tongue, floor of the mouth, and pillars of the fauces. Etiology for oral mucous squamous cell carcinoma, no single clear recognizable factor. It's a multi-factor disease, and probably what happens is that you've got genetically susceptible people who, under certain circumstances of environmental factors and carcinogenic factors, will then go on to develop cancer. And some of the high-risk habits or factors are sunlight, tobacco, alcohol, nutritional factors. Vitamin A and C can have a protectional effect, or on the converse, lack of that can have a risk factor. Infections by viruses and candida are also suggested to play some sort of part. So sunlight basically may increase incidence in lower lip cancer, and a mechanism suggested there is alteration to the genetic material. Tobacco, most studies have found that there's an increase in risk of intraoral cancer associated with cigarette consumption, whether it be smoking or smokeless tobacco or chewed tobacco with included betel quid. And it may just be that they contain chemical carcinogens such as nitrosamines and aromatic hydrocarbons. Alcohol also shows an increased risk, and it may be that the pure ethanol doesn't appear to be carcinogenic, so it may just be that role of additives that have been included in the alcohol, and they may play a part in acting as a solvent or facilitating the passage of tobacco-related carcinogens into the deeper tissues. And interestingly, that the risk of tobacco and alcohol alone is not, or the risk of alcohol and tobacco together is not double the risk of alcohol and tobacco by themselves, but there's a synergistic effect, so it's a much greater effect than double. Nutritional factors, we know that iron deficiency can be associated with certain throat cancers, and vitamin A and C, as mentioned before, has a protective measure towards tissue changes. So let's talk about viruses. We know that human papillomavirus is implicated in cervical carcinomas, but it doesn't seem to be detected in most of the oral carcinomas. However, HPV is implicated in throat carcinomas. And we know that HPV can immortalize oral keratinocytes in vitro, and these cells may then undergo malignant transformation in the presence of tobacco products. Some other the role of infections and evidence for why infections may be associated with oral carcinoma. We know that H. pylori, Helicobacter pylori, is associated with gastric adenocarcinoma. We know, as mentioned before, HPV is associated with cervical carcinoma, and we know that hepatitis B and C and hepatocellular carcinoma have an association. So what about the role of fungi in carcinogenesis? There doesn't seem to be any apparent association, but there is some evidence to implicate the possibility of the role of Candida in the susceptible person. So when we go back to viruses and SCC, we know that a study done by Califano et al. That human papillomavirus infection with high-risk types of 16 and 18 has been widely reported as one of the prominent mechanisms behind the development of cervical squamous cell carcinoma, and links between HPV and oral cavity carcinoma has been suggested, but there's no total evidence as such yet. So, evidence for association of Candida with leukoplakia. We know that Candida leukoplakia, or chronic hyperplastic candidosis, which is an adherent white plaque, has a higher risk of malignant change. And if you did a biopsy on that and stain it with PAS, you can see the hyphae that are in the epithelial layer. We also know that there's evidence in the literature about the chronic hyperplastic candidosis undergoing malignant change. And non-homogeneous leukoplakia, which is frequently infected by Candida, also tends to have a higher or greater rate of malignant transformation than other homogeneous leukoplakia. So the progression to dysplasia may be advanced by Candida albicans, but the presence of Candida albicans doesn't prove a causal relationship. We know that Candida is a commensal pathogen or opportunistic, and so if you've got rough areas in the mouth, then it's more likely that they're going to be found in those areas. But the possible mechanisms through which Candida influences carcinogenesis is that it can colonize epithelium, and it has the ability to produce carcinogens, which can then initiate carcinogenesis. It has the ability to promote carcinogenesis in initiated epithelium. It has the ability to metabolize pro-carcinogens and turning them into carcinogens. It has the ability to modify the microenvironment and induce chronic inflammation. So it may present in the oral cavity in many ways, like a pseudomembranous candidosis, which is a milk curd-like plaque which wipes off, leaving an underlying red surface, or it could be an adherent plaque which doesn't wipe off and needs to be biopsied to look at, or it could occur as a denture-induced candidosis, where this red area is underneath the fitting surface of the denture, and here also in this posterior area you can see some erythematous areas. So oral candidoses are quite often seen with ill-fitting dentures, poor oral hygiene, and if you remove the denture at night, leave it dry. Candida doesn't like drying, it dies with drying. Or twice a weekly you soak it in some dilute bleach or white vinegar. Management of candidosis, miconazole, 2% gel, 4 times daily for up to 3 weeks, maybe 4. Remember that miconazole can potentiate the effect of warfarin. Amphotericin, also as a lozenge, can be sucked 4 times a day, again for about 3 to 4 weeks. So management of SCC from the 1900s to 2015 and beyond looks a little bit like this. In the early days, we only had surgery. There's no other modalities available. In the 1920s, radiotherapy came in, so combination therapy was available. And in the 40s, therapeutic agents, and more recently, immunotherapy, and in the future, gene therapy will allow us to have a combination of many modalities that can give the patient a better prognosis. But the best prognosis is the diagnosis of the condition early. So this is why, as general dental practitioners, you need to make sure that if you see that white patch or red patch, even though it might look innocuous, need to get that referred and looked into. So in summary, etiological factors, we know chromosomal aberrations, including insertion, deletion, and amplification, can lead to mutations that may progress to cancer. We know that tobacco, alcohol, and other chemical factors can have a increased risk. We know that sunlight also, especially with lower lip carcinomas, can be at high risk. And then we know that genetic factors are there. There may be genetic susceptibility, and this could involve oncogene activation, tumor suppression, inhibition, amplification of chromosomes in certain carcinomas. And we know that immunosuppression will reduce our ability to provide an immune response to these changes. And we know that hematinic deficiencies also will interfere with cell repair and also reduce our immune ability. And the role of infections such as viruses, HPV, P16, and Candida have to be taken into consideration. So the diagnosis, a good history, looking at the risk factors, looking at the site of the lesion, and doing a biopsy, maybe carrying out some blood tests and imaging. And the management of an SCC involves management of the primary site, looking at the neck status, so if there's any lymph node involved, quite often neck dissection is carried out to remove all the lymph nodes, looking for any metastasis, then the reconstruction of the defect after surgery and radiotherapy, and then in combination with the surgical team, you may want to be involved with the reconstruction and functional outcomes. Future advances, we know that there are advances being made all the time, and there are some gene therapy issues that are perhaps might look promising, as well as optical coherence tomography, which is a imaging technique which allows images to be captured up to 2 millimeters from the mucosal surface based on the detection of light backscattered off tissue boundaries. So oral mucosal squamous cell carcinoma is a very important topic for you to learn. Basically, early diagnosis of the carcinoma can mean that you may have saved someone's life. And this indicates the fact that the thickness of the involved mucosa, as it gets longer or deeper, then the basically survival is reduced. So the survival rate with single modality treatment, also I'd say surgery, is worse than if you've got the two together. So we know that if you've got a clinically, basically clinically and radiologically negative neck, observation or irradiation, or selective neck dissection, and quite often most surgeons will go for that option. And if it's a single positive node, post-operative radiotherapy to the neck may be required. Primary requires radiation as well. And if you've got clinically positive neck, comprehensive neck dissection is required, and multiple nodes or extra capsular spread may occur on pathological examination. Thank you very much.